Hello, everybody. Welcome to Grand Rounds. We are delighted to have you with us for a very special talk all the way from the West Coast. We welcome our special guest, Dr. Monica Gandhi. She's an infectious disease doctor, a professor of medicine, and the associate chief in the division of HIV, infectious disease, and global medicine at the University of California, San Francisco. She's also the director of the UCSF Center for AIDS Research and the medical director of the HIV clinic at San Francisco General Hospital. Her research focuses on HIV in women and adherence measurement in HIV treatment and prevention, and most recently, of course, on how to mitigate the COVID-19 pandemic. And now we've got lots of other pandemics to talk about as well. With that, we welcome Dr. Gandhi.
Well, thank you so much. It's so nice to be here. I have always loved Mount Sinai when I came once to interview many years ago. So I just actually wanted to talk about HIV updates really in line of World AIDS Day. And that is 12/1/2022. And I would be really happy if you, ask questions anytime, and I'll leave time for sure for that. And we'll have some interactive aspects of this. What I'm going to talk about today is really the history of HIV into human populations, which I think is something that we don't talk enough about. I think it relates to COVID and our treatment of animals and zoonoses. I want to talk about this current state of the pandemic, where we are kind of not in terms of novel HIV treatment, novel HIV prevention in 2022, and then just comment on HIV cure and vaccine. So kind of touch everything in HIV medicine. In terms of history, we all know that HIV is a retrovirus. This is, of course, a virus that starts out as an RNA virus, goes into become a DNA virus. And we know where it came from because we have examples in essentially the animal kingdom of retroviruses living with other primate species. So all primate species live with simian immunodeficiency viruses. And at a certain point, an SIV strain really jumped from the primate species into human species. And so the questions that come up is, when did this happen? How did this happen? And what was the defining event? Well, we first have to remember how HIV is divided. There are really two major types of HIV around the world. There's HIV-1, which is the predominant strain, and actually 90% of the world's infections are group M in the HIV subtype 1. Then there are some very rare groups that came from other primates. Group M came from the SIV strain that's most closely related to the SIV strain in chimpanzees. Then there's HIV group 2. This is found more in West Africa, less virulent than HIV-1. And it's also found in countries that colonized West Africa. And that HIV-2 is most closely related to the SIV strain in Pseudomangabes. So the first theory that was ever propounded how HIV entered human populations was actually this entire book that was published in 1999. This ended up not being correct, but it was a very interesting investigative reporting by Edward Hooper. And his idea was that the entrance of HIV into human populations came from the polio vaccination campaign. One had happened is Sabin, of course, had invented the oral vaccine. Salk had invented the inactivated vaccine, but there was another oral vaccine that was invented in the 1950s around the same time as the Sabin vaccine, invented by a scientist named Hilary Kaprowski. The NIH held a meeting in 1957, said, which vaccine's better? And they said, Sabin, your vaccine's more effective. Let's use this one in terms of the oral vaccine. But Kaprowski did end up vaccinating about 1 million Africans in what was called Belgium-controlled Congo at the time. And this entire book says, well, I think it was from that mass vaccination campaign because this oral vaccine was made in primate cells. Now, it turned out it was not the right primate. This was African green monkey kidney cells. It was not the right timing. This is not the origin of HIV into human species, but it was an interesting investigation. What was actually the crossover event? It was the bushmeat trade. And this is really the practice of slaughtering and killing and eating primates for food. And it is this practice that grew up with firearms in the 1900s, mostly in West Africa, that led to essentially hunter's blood being exposed to SIV strains from many different primates. And then essentially one strain just had to be sexually spread efficiently from human to human to get HIV to really transmit efficiently in humans. And so that crossover event was from the bushmeat trade. But the question is now, when did that happen? When did HIV enter human populations? Well, this is an interesting old case report from the Lancet in 1959. It was interesting because this man who they describe has all the features of having severe immunosuppression, had a remorseless anal lesion, pneumonia, ulcer eating into his upper lip, cytomegalovirus, pneumocystis. And there was a report in the Lancet that actually said, oh, we found specimens from this individual in 1959, and he did have HIV. That was in the Manchester Royal Infirmary. However, the London School of Tropical Medicine and Hygiene requested specimens and they didn't have any left, so they really couldn't prove that this was HIV. So in terms of really proving when HIV entered human populations, one issue is that HIV doesn't go into bones, it doesn't go into hair cells, and so we really need plasma specimens or lymph tissue to know when HIV entered human populations. So this was a publication from Beatrice Hahn in Science 2000, where there were 1,200 plasma specimens that a University of Washington lab had stored from 1959, which is what was then called Zaire and now called the Democratic Republic of Congo. And they sequenced all 1,200 of these plasma specimens and they found one had HIV. And so what this group did in science is they looked phylogenetically at what the HIV strain in humans looked like in the year 2000, what the SIV strain looked like in chimpanzees, and what they called the Zaire 59 strain looked like in 1959, did phylogenetic analysis and estimated HIV entered humans in the 1930s. Now, that was actually the prevailing thought for about 8 years until Michael Warby published this paper in Nature, where another strain was found around that same time in the Democratic Republic of Congo called the DRC60 strain. This HIV strain was found in a lymph node of an adult female who had died of lymphoma. And so when they looked at DRC60 and Zaire 59, they said, okay, if HIV has been circulating in human populations in the 1930s, we'd expect them to look more alike. They didn't look alike at all. It turns out that phylogenetically speaking, HIV has been in humans longer than since the 1930s, and they placed the entrance of HIV into human populations sometime between 1884 and 1924. Really around the turn of the 20th century is when HIV came into human populations. And that is our latest data. That is our latest thoughts about when HIV came in. And so why did we just start seeing HIV in the early 1980s? Why did we describe it then? Because really it was circulating in West Africa. And at the time, actually cities were very far apart. They were very low population density. And it was really, this is a figure from the Michael Warby paper. It was really with the growth of cities, with colonialization, with the establishment of trade, with the establishment of the sex trade, that essentially conditions could be set up for spread of HIV. And by the 1950s, Kinshasa was over 100,000 people. And really at this point, the conditions were set up for spread. We didn't know that HIV was happening. It looked like other diseases, it looked like other tropical diseases, but really what had to happen is HIV, unfortunately, had to go from West Africa to East Africa, and then the conditions were really set up for massive spread, because in East Africa, there were low rates of circumcision of men. There were high rates of STDs. There was lots of movement and trade and truck workers. There was low status of women. And all of that led to the conditions that set up spread in East Africa, really starting in the 1970s. And by 1986, 85% of commercial sex workers in Nairobi were infected with HIV. And then it spread down the Tanzam Road to South Africa, to Zimbabwe. And we really saw the massive spread in East and Southern Africa over the 1980s. This is the map of HIV in 1985, coming over from West Africa over into East Africa. This is the map in 1995. By this time, really high spread in East and Southern Africa. And by this time, we of course had seen spread over North America, but the prevalence has always been highest in these regions. And then by 2005, with the breakdown of the former Soviet Union, there was spread that really occurred in Eastern Europe and all those former states because mostly of persons who used drugs with the opiate trade at that time. And now I can tell you, what is the state of the pandemic in 2021? Well, I'll first ask a question, and feel free to just put it in the chat or, answer. But it's a question to you, which is how many people are currently living with HIV as of the current moment? And we have data as of the end of the year 2021. Is it 18 million, 25, 32 million, 38 million, or 50 million? And I'm going to look at the chat, or people can say it. So this is interesting because one kind of pessimistic answer is 50 million. Luckily, not that high, not as low as 32 million, and it is 38 million. That is actually the right answer. And so this is the map of the current statistics from UNAIDS that were put out as of the end of July 2022. 38.4 million people are living with HIV worldwide. 20.6 are in East and Southern Africa. It is important to note that this is the highest rate of HIV, the highest prevalence of HIV that we have had. And the other thing that we have seen is major derailment of our HIV goals during the COVID pandemic. The UNAIDS usually puts out every 2 years a report that is labeled something pretty hopeful. But this year, unfortunately, the report on July 28th was labeled in danger, because why UNAIDS said in danger is we have had a massive sort of setbacks in our HIV response during the COVID pandemic. We had 1.5 million new infections in the year 2021. We thought we'd be much lower than that in 2021, at least down to 1 million. We have had 40.3 million deaths from HIV since the beginning of the pandemic. Last year, 75% of people living with HIV worldwide have access to antiretroviral therapy, but that means 25% don't. And among children, actually only 52% of children have access to HIV therapy. Last year, 650,000 deaths from HIV, which means every minute that we've been talking, there's been another death from HIV. So it really has been a major setback in our global AIDS response, and we need to do both at the same time. Again, we thought that by this year of 2021, we'd be much lower than 1.5 million new infections. We thought we'd be down to at least 1 million, with the goal of 2025 being 500,000 new infections, but we had many more infections last year than we thought. So let's turn to HIV in the United States and see where we are. There have been derailment of our goals here, but where are we in the epidemic here in the US? Well, it is an important day to say that it has been now 40 years since the first clinical description of AIDS. So last year in World AIDS Day, that marked the 40 years of this very landmark CDC MMWR report on June 5th, followed by one on July 4th that really described these terrible opportunistic infections, cytomegalovirus, Kaposi sarcoma, pneumocystis, in essentially these young gay men living in Miami, New York, San Francisco, LA, Philadelphia. And it was tragic if you looked at the death rate of these 271 cases described in these two case reports, 121 deaths out of those 271 cases. We became, in San Francisco, along with you in New York, the epicenter of the epidemic here in the US. 1984, the San Francisco Chronicle called AIDS the year of the plague, the HIV, the year of the plague here in San Francisco. Here are men fighting for their lives and marching on City Hall. We'll be doing this again on World AIDS Day this Thursday. And if you look at the kind of history of the HIV epidemic in the US, again, of those 270 cases, 121 had died. By 1982, the gay-related immunodeficiency virus, ill-named, was relabeled AIDS by the CDC. By 1983, this was the first time that a gay couple ever appeared on the cover of a major magazine. This is Bobby Campbell and his partner, Bobby Hilliard, on the cover of Newsweek. By 1983, the virus was isolated and an antibody test was developed. 1983 was when we opened our doors. I'm the medical director of Ward 86 here at UCSF, and That was, I think, one of the oldest HIV clinics in the country. We're celebrating our 40th anniversary this January. Bathhouses in 1984 were closed in New York and San Francisco. And by 1985, and this took longer than we thought it would, the first commercial ELISA was approved for HIV. In terms of 1985, you kind of see the kind of mixed messaging and confusion that I think was occurring with COVID. Here, you could see that a major science magazine in 1985 said this doesn't affect heterosexuals. This is really the price you have to pay for anal sex. Newsweek, on the other hand, Life, on the other hand, that year said HIV can infect anyone. And that year, 1985, was the year that Rock Hudson had told us that he had HIV, and he died that year from HIV. And that was also the year that a little boy named Ryan White was banned from entering a school by parents who were holding up signs. He had acquired HIV from hemophilia, with which he was born, and he actually could not go to school that year at the age of 11. All this mixed messaging again in the 1980s, 1986, you can't catch up from a glass, you can't catch up from a handshake. All that is true. And we started ramping up testing, but without treatment at the time. In 1987, out of grief, really, this project started on Market Street here in San Francisco called the Names Project, where a specific panel of a quilt was devoted to anyone who had died of HIV. And in 1987, here is the AIDS quilt spread across the Washington Mall. By 1990, that little boy who had grown up to only be 18 died of HIV. And in August of 1990, really, Congress passed a bipartisan disease-specific program, one of the only ones that we have in this country. And HIV has had bipartisan support from Congress at the level of NIH, at the level of Congress, at the level of HRSA, the CDC, ever since. And essentially, this is a program that supports low-income clinics to provide wraparound care, social work care, other care for people living with HIV. By 1992, AIDS was the leading cause of death of US men between the ages of 22 and 44. And in 1995, over 500,000 AIDS cases in our country. 2010, Obama started the National HIV/AIDS Strategy. And in 2019, the Trump administration started the Ending the HIV Epidemic Initiative. And that is our current initiative. That is the description of the initiative that we're using under the Biden administration as well to try to end HIV. And it really has 4 pillars. One is testing, one is prevention, one is treatment, and the 4th is responding to outbreaks. So this is the map of the US in terms of our current HIV cases. And if you look at this, you can see that, of course, California, Northeast, we have had HIV, but really what we've seen rising over the last 10 years is this high prevalence of HIV infection in the South and Southeast of our country. And unfortunately, it is these regions that have the fewest HIV doctors, that is the fewest governors expanding Medicaid, for example. And unfortunately, if you look a map at virologic suppression, where virologic suppression here, the lighter areas, show higher rates of virologic suppression, you can see that the lower rates of virologic suppression are also occurring on HIV therapy in Texas, in the South. And so we have a lot of work to do still on HIV, and we have seen setbacks again in our response during the COVID pandemic, especially in terms of distribution of pre-exposure prophylaxis. If you look at the map of new HIV infections, really as the latest CDC statistics, 52% of our new infections are in the South. This really maps directly on poverty in the United States, interpersonal violence, incarceration. This has been always a disease that really clusters with social injustice. And you can see this sort of incredible rate of new HIV diagnoses, especially among men who have sex with men of color. So a lot of work to do. So I will now turn to treatment, but before I do that, it'll be really interesting to hear from you what you think. Of course, the goal of HIV therapy is virologic suppression, having a viral load that's undetectable in the bloodstream. But what percentage of the world's population who's on therapy, not even those who don't have access to therapy, let's just say who's on therapy, those 75% of adults, who are on therapy, what percentage of the world's population on therapy is virologically suppressed? Is it 40%, 52%, 79%, 88%, or have we achieved our UNAIDS goal of 95%? Okay, someone is, again, really pessimistic at 52%, so it is higher than that. But it is what the majority of people have written here. It's 79%. And so high if compliant would guess 4. Someone said that it's true. It is adherence that has led to these lower rates of virologic suppression. So we're at about 79%. So let me summarize that data for you. So essentially, there were 2 big studies published last year, one from the US and actually one in Lancet HIV across the planet. And even in the US, 40% of people report adherence that's less than 80%. So it is hard. There's a number of barriers to adherence. And it really has to do with so many different reasons. I think the US reasons are different than in the international setting. US regions, especially in our 2 cities, tend to be there's mental illness, there's substance use, and homelessness. I think those are the 3 major social determinants of health that really interfere with adherence. In the international setting, much more aspects of stigma. There were a lot of stockouts during the COVID pandemic of ART, and you can't take your HIV medication and bring it home if everyone in the house doesn't think that you have HIV, or that you're going to be accused of, for example, in India, a daughter-in-law carrying HIV medication tells the mother-in-law you gave it to her son, which is not what happened. So it really is different reasons in different settings, but the adherence rate is not where we want it to be. The big Lancet HIV summary of this was last year, and essentially in adults on ART, there's a 79% virologic suppression rate at 1 year. 65% at 3 years, and in children, the virologic suppression rates are even lower. So we have a lot of work to do to increase adherence, which often, again, accompanies social determinants. So, and then it's not just HIV treatment where we have low rates of adherence, it's also in the context of pre-exposure prophylaxis. A systematic review in Lancet HIV last year showed that 41% of those who started on PrEP worldwide discontinued within 3 months, within 6 months. And even those who stayed on it, there was high rates of suboptimal adherence. And so only about 63% had good rates of adherence. So again, we have a lot of work to do. And I think that the reason I want to talk to you about the latest updates in HIV medicine around treatment and prevention being long-acting is that many people think that long-acting medications can help us with some of these barriers. So let's turn to the latest advances in HIV treatment. And I think really the biggest updates that have occurred up to the date of 2022, where we are right now on World AIDS Day, are the advent of long-acting antiretroviral treatments and prevention. So I want to delve into the data on those a little bit more. When we were talking about long-acting antiretroviral treatments and prevention, everyone who treated HIV wanted it for sort of 2 populations. One were highly adherent people who were just tired of taking HIV medications every day, or had pill fatigue, or really did well with taking it every day, but just didn't want to take a pill every day. And that always was the population that was of interest. But those of us who work, especially as we all do with underprivileged populations, we really wanted this for people who had barriers to adherence, who were homeless, who used substances, who really couldn't take their pills every day. But unfortunately, the trials did not study the poorly adherent or patients with adherence challenges. So I'm going to tell you both about the clinical trials for the new HIV long-acting treatment, and then about a demonstration project here at Ward 86 in using the long-acting treatment in those who have adherence challenges. So if you think about the registrational trials that define the use of the long-acting treatment, there's only one that's approved so far. And that long-acting treatment that's approved so far is called cabotegravir, which is a long-acting treatment that's an integrase strand transferase inhibitor, or what we call an INSTI, and then rilpivirine, which is a non-nucleoside reverse transcriptase inhibitor. And the combination of long-acting cabotegravir and rilpivirine is the only long-acting treatment that we have approved in this country. And it was approved at the beginning of January 2021. And there were essentially 3 pivotal trials that formed the basis of the approval of long-acting treatment for people living with HIV. There was the FLAIR trial, which looked at long-acting cabotegravir and rilpivirine in treatment-naive individuals. There was the ATLAS trial that looked at the same combination, but in treatment-experienced individuals. And ATLAS 2M actually looked at giving the same long-acting treatment, but every 8 weeks instead of every 4 weeks, which was the design in FLAIR and ATLAS. So I want to tell you a little bit about that data. The FLAIR study was again looked at only in treatment-naive populations. Now, importantly, the design of the FLAIR study is really important to mention because no one went on long-acting cabotegravir and rilpivirine de novo. They started from their treatment-naive condition. They were put on an oral regimen, dolutegravir, bacavir, and 3-TC for at least 16 weeks, mostly 20. Then they suppressed on that regimen, and then they were allowed to switch over to cabotegravir, rilpivirine, given as injections, 2 separate injections every 4 weeks. And that was the design of FLAIR. Then what the design of ATLAS was, and I always think of ATLAS as traveling the world, and so you've had treatment experience, but essentially the ATLAS study looked at patients who were virologically suppressed, didn't have a prior history of virologic failure, and they were suppressed on whatever regimen they were suppressed on, and after at least 6 months of suppression, they were switched over to every 4 weeks long-acting cabotegravir and rilpivirine. And then finally, the design, and I wanted to tell you about the updates on these studies, and I'll tell you about ATLAS 2M. The FLAIR study, we have data essentially out to week 124, and there were high rates of virologic suppression when switching over to long-acting cabotegravir and rilpivirine, but there were some failures, and I'm going to tell you about those failures in a minute because those failures are important, but essentially relatively high rates of virologic suppression out to 152 weeks. ATLAS, this is the 96-week data, and we have even longer data at this point that isn't published, but essentially also high rates of virologic suppression when switching over to the long-acting cabotegravir and rilpivirine. And then what was the design of ATLAS 2M? This essentially took patients who were virologically suppressed on their oral therapy, the patients from ATLAS, the participants from ATLAS, and they rolled over in getting it every 8 weeks, but at a higher dose. And then some new participants came in and got every 8 weeks at a higher dose, 600 milligrams of cabotegravir, 900 milligrams of rilpivirine every 8 weeks. And how did participants in ATLAS 2M did? We have data out to 152 weeks, again, relatively high rates of virologic suppression, about 88% virologic suppression over 152 weeks, getting cabotegravir and rilpivirine every 8 weeks. That's an injection essentially 6 times a year. So it is important to mention, though, that there is a certain virologic suppression rate, but it's not very high. So what is any guesses here that there was an updated pooled analysis presented at the HIV Glasgow meeting on October 26 in Scotland, but what was the 152-week virologic failure rate on long-acting cabotegravir and rilpivirine in FLAIR, ATLAS, and ATLAS 2M? And any guesses? I'm going to look at the chat. Three 3%, 1%. Okay, Dr. Lafney, you were very pessimistic about the rates of virologic suppression worldwide. No, you thought it was 50 million people living, so you were more pessimistic there, but you're very optimistic about long-acting. You say 1%. And it is close, actually. So you were close. So essentially, and then someone said 3. It was 1.4%. So it is a really low rate of virologic failure. The one issue, though, is that if you fail with long-acting cabotegravir and rilpivirine, you fail hard, and you fail with INSTI mutations. And so that is the one thing that has given the WHO pause. And I want to talk about that next. So what do we know about the failures? Well, again, very low rate of failure. This is 1,224 participants across all 3 trials, and there's a 1.4% virologic failure rate total. But of the people who failed, they do develop integrase inhibitor mutations, as you can see in the first column, and they develop a lot of NNRTI mutations. And why is that concerning? Because first-line antiretroviral therapy worldwide is dolutegravir, tenofovir, lamivudine. If you develop N155s and Q148s and G148s, you have just lost first-line therapy worldwide, which is dolutegravir. And so it is of concern. And essentially, the WHO has actually not endorsed long-acting cabotegravir and rilpivirine worldwide as of their latest treatment guidelines, which is an interesting dichotomy, because many people are saying you need to endorse long-acting cabotegravir and rilpivirine because it's going to be easier to take. It overcomes these barriers to adherence. And others are saying we can't risk it. We can't risk this even low rate of failure, about 38.4 million people living. And there's a completely vociferous argument going on right now at the WHO and worldwide about the approval of these worldwide. But right now, these are not recommended on worldwide guidelines. So in terms of this country, where Europe and US, these are recommended, of the below risk factors for virologic failure across trials, which one can you circumvent by different ways of administering the injection? So this is kind of an interesting question, but is there a different way to administer the injections that make you circumvent that essentially you can kind of get around? Is it low rilpivirine trough concentrations? Is it the HIV subtype, but you can give it in a different way? Is it having a high body mass index? Is it having a history of rilpivirine mutations, or a low BMI? And this is just a guess, but I think it's important. I think it's interesting for those of us who are using these drugs. So anything in the chat? Okay, so high BMI, excellent. Low troughs, and that's actually true because it gets around the low troughs. So let me explain that. So this is excellent. So it's very interesting, but I don't think, for those of you maybe on this call who use injectable drugs, you probably, for example, antipsychotics or contraception, you're probably more aware than we had become in HIV medicine how important the injection is to any of these long-acting drugs, putting it in the right space, getting it in the sub-Q space if it needs to be sub-Q, getting it in this intramuscular compartment if it needs to be intramuscular. And essentially what we saw with those virologic failures that I talked about in FLAIR, ATLAS, and ATLAS-2M is that there were essentially 4 major risk factors that came out for failing. One was having a high BMI of above 30 kilograms per meter squared. One was having low rilpivirine troughs. One was having rilpivirine associated mutations in your proviral DNA in the past, and one was your HIV subtype. You can't change having rilpivirine associated mutations. You can't change your HIV subtype, but what you can change is how you administer the drug in settings of high BMIs. So what we usually do is we give it in the lateral gluteal muscle, 1 shot in one shot in the other. And what this, oh, I'm so sorry, I didn't show the picture. Oh, sorry, here it is. What this study showed that in high BMI, you have a lot of subcutaneous tissue, and you actually need to use a longer needle to get, we use 2-inch needles here at Ward 86, to get the drug into the intramuscular compartment. And what this MRI shows is that if you use a longer needle and you get it deep into the space, you see more of a distribution of these drugs into the compartments they need to be, and then it elutes out over time. So a little trick for you, anyone that has a higher BMI, we are actually using 25 in our clinic, we're using a longer needle for the injection. Okay, so I've just told you about these long-acting treatments. I've told you they're great. I've told you they're amazing. I've told you that they work really well, but I've told you that they've only been studied in the patient populations that in a way need them the least, that are able to take their drugs every day. And so what about the idea of long-acting injectables, either worldwide or in the US, in patient populations that have low adherence because of all of these barriers to adherence. And I think it's a critically important population to study. We call it hardly reached, but because essentially 10% of our population living with HIV in the US is essentially holding 90% of the virus. And it is these patient populations that we all know have all these barriers. So, oops. Oh, I'm so sorry. Some of my slides got lost, and I am very sorry about that. Let me just quickly go to my other slides to tell you about our program at Ward 86, and I'm going to come back to PrEP. Really sorry about that. I will take any questions as I'm bringing up this other slide when something got messed up with my slide presentation. I really apologize. Okay, so what I want to tell you about is our patient program at Ward 86, where we have in our clinic looking at these long-acting antiretroviral treatment regimens in adherence challenge patients. So one thing I do want to remind you is, again, the WHO has not put long-acting treatment on their guidelines. They've only put HIV prevention with long-acting cabotegravir, which I'm going to talk about next, on their guidelines, but not treatment. So what have we done at Ward 86? Well, a couple of other issues. You do have a cold chain, which is another one of the reasons that the WHO has not yet approved rilpivirine and cabotegravir for dissemination worldwide. They can be kept out of the fridge for only about 6 hours. So I'll kind of cut to the chase here. Ward 86 is our clinic that we opened our doors at San Francisco General in January 1983. This is the initial memo letter that gave us the top floor of Building 80, which is why it's called Ward 86 in 1983. And our patients at Ward 86 are essentially mostly publicly insured. 96% are on Medicaid or Medicare. They, especially during the pandemic, have had increased rates of anxiety, depression, major mental illness. We have a lot of poverty. We have high rates of addiction. Our drug, unlike yours in New York, is methamphetamine, 35% methamphetamine use, and 34% of our patients are marginally housed. So this does not look like the patient population that was studied in the FLAIR and ATLAS clinical trials. However, we really, really wanted to try these medications in the context of patients who had a hard time taking oral therapy. We actually call them Hail Marys, because these are patients that otherwise would not be suppressed for a variety of reasons, could not take their oral therapy every day. And so we put out a protocol that is actually publicly available on the San Francisco Getting to Zero website. Anyone can download it. We have a very defined, detailed protocol in using long-acting antiretroviral therapy in virologically non-suppressed patients. And we also have tried using this in our homeless patients, because in the city of San Francisco, 75% of those who are housed are virologically suppressed, but only 27% of those living with HIV who are homeless are virologically suppressed. And we already talked about the inclusion criteria of the trials. You had to be virologically suppressed on an oral regimen first, no history of virologic failure, no mutations except a K103N that rilpivirine will cover. And also the FDA has already allowed a direct to inject protocol. And what we did here at Ward 86 is we said, you don't have to be virologically suppressed. You just have to say and prove to us that you can't take oral medications. We go direct to inject. We also don't allow in any mutations. And the only thing that we've asked of participants who have come in for our protocol to use long-acting ART is essentially that they will come in, that they give us some ability to contact them to get them to come in every 4 weeks for their injections. And these are our results so far. We hired a pharm tech to help us get the injectable meds. We have meetings every other week with our PharmD, our pharm tech, our clinic leadership. We go over each patient that we have on injectables in our protocol in detail. And I'm now going to give you fresh off the press data of 122 patients who've been started on long-acting ART at Ward 86. None of this is actually published yet. We only have published results on the first 51 patients. Of the patients we've started on long-acting ARVs at Ward 86, I want to point out that 54% are unstably housed. Again, most of them are on public insurance. 39% use methamphetamines. We were able to get a high proportion, relatively high proportion on-time injections, 73%. And of the 100 people, because I'm telling you the data for the first 100 patients at Ward 86, 41 were not virologically suppressed and 59 were virologically suppressed. And you can see that those who are not virologically suppressed here at the bottom had much lower CD4 cell counts. These are really patients who otherwise were not able to take oral therapy, and we were very worried about them. And our results so far, and we're putting this data together now for publication, is that 100 patients who started, the 59 who started with baseline suppression, all remain suppressed. And of the 41 who started with virologic non-suppression, actually 98% suppressed. And then 2 had the log reduction that we would have expected. So we have had very good results with using long-acting antiretroviral therapy, even on virologically non-suppressed patients. This is not in the guidelines. This is not approved by the FDA. But again, we do this when we really don't think we have another choice and that we're saving lives. And there have been a couple of other demonstration projects around the world, including in the OPERA cohort that was published, that was shown at ID Week, that shows similar results to ours. And so this is our Kaplan-Meier plot that shows that at 12 weeks, we are going to, that 80% of patients did suppress if they started out virologically non-suppressed. And we predict that we're going to have around the same virologic failure rate, which is 1.4%, than they've seen in the clinical trials. So if you're able to get patients in, I think it works well. Okay, so I next want to ask you, what long-acting medication are you excited about next? Are you excited about islatravir, lenacapavir, the TAF implant, iberdomide? And I'm curious to see what you think. I really want Bill Lafney to answer because you're so good about answering. TAF implant, because it sounds like a novel delivery system. Implant, also Bill. Lenacapavir, exciting. You know, this is excellent. Now, TAF implant's really far away. I totally agree with you. It'd be amazing. We're not close. And the closest thing we have is lenacapavir. So I want to tell you about lenacapavir. And the reason is that by December 27th in this country, this year, we're probably going to get lenacapavir. So let me tell you about that. So what is lenacapavir? Well, it's a very interesting first-in-kind novel HIV capsid inhibitor. Remember, the life cycle of the virus goes through entry inhibitors, then it enters, then it uncoats, and then it has its reverse transcriptase, and all these drugs work at the RT level, and then it goes in, the DNA goes inside and integrates into the host cell chromosome. Integrase inhibitors work at that level, and then it harnesses the transcriptional and translational machinery of the cell, makes a big viral polyprotein, needs to be cut up into smaller proteins by the viral protease. Protease inhibitors work at that level, and then viral particles are made and they are encapsulated. And essentially, the lenacapavir is the first HIV capsid inhibitor. So it works at the stage of viral assembly. And the important thing about the capsid inhibitor is that it's extremely potent and it can be given literally 1 injection subcutaneously every 6 months. This is revolutionary. Every 6 months, I just told you about every 4 weeks, but what about a drug that you can give every 6 months subcutaneously? So what is the data that we have on lenacapavir? This is the Capella study. It was published in the New England Journal in the spring, and essentially it looked at patients with multi-drug resistant HIV. These are patients who have a lot of drug resistance. They only have a regimen that barely works in terms of their background regimen. And participants were put on lenacapavir, first actually as monotherapy with the failing regimen, then they optimized their background regimen, and then they looked at lenacapavir versus the optimized background regimen as placebo. And essentially, there were higher rates of virologic suppression when you added lenacapavir to MDR HIV participants. And this is the figure from the New England Journal study. And you can see that actually, the more drugs that you have in the background, the better. Like having 1 active drug in the background is better than having 0, because lenacapavir cannot hold up by itself. We've never been using monotherapy in HIV. So This lenacapavir was approved for MDR HIV in Europe, and the FDA meeting for this is December 27th, and we are very excited because it's absolutely expected to pass, and we will then have an option for our MDR HIV patients where you again inject subcutaneously only every 26 weeks, and you can suppress patients. Are people going to use this in treatment naive patients before we have data in treatment naive patients? Of course they are. And that's what we did with the long-acting cabotegravir and rilpivirine, even in patients who are virologically non-suppressed. I do anticipate that people are going to try to use lenacapavir with other background agents, maybe cabotegravir every 2 months, maybe cabotegravir and rilpivirine every 2 months, maybe an oral regimen once a day with lenacapavir, and it's being studied in a treatment-naive trial called Calibrate, compared with a background regimen of TAF FTC. So I think lenacapavir is next on the horizon. It's also going to be studied and is in clinical trials right now called the Purpose 1 and Purpose 2 studies, to be studied as prevention every 6 months. Every 6 months, a preventative agent, that's all, twice a year. Really amazing. We'll see those results in about a year. Okay, so now I'm going to turn over to now what are our updates in prevention. And now I have to go back to my other slides where things did get updated. Okay, so the biggest, and you can see these, so the biggest update in HIV prevention is essentially what I just said to you for treatment, but just cabotegravir. And so what we basically, the new injectable form of PrEP, I would be curious what you think. Does cabotegravir protect from HIV kind of just as well as daily oral PrEP, inferiorly, or is it actually superior to daily oral PrEP for protection from HIV? And I'm keeping tabs for us to have some time. Equal someone, and we'll talk about long-acting and Iris. That's a very good question. And AIDS defining complex, yes. Superior. See, okay, I love philosophy because you are right. It is. It's incredible. Actually, it was amazing what these results showed. And I don't think anyone expected this, or I'm not sure they expected this, but it really has to do with it's hard to take a daily oral pill once a day. And it's been hard since 2012. You feel perfectly well and you're taking preventative agent. How many people can't take calcium, vitamin D, preventative medications? And adherence has been the Achilles heel of daily oral PrEP. And so essentially, remember, what did we have before injectables? Well, for cisgender women, unfortunately, only daily oral TDF and FTC was approved. Now, for MSM and transgender women, there are actually more options. We can use daily TDF FTC, daily TAF FTC, and also use on-demand TDF FTC, which is 2-1-1 regimen. That's taking the 2 tablets before sex and then 1 tablet after 24 hours and then 1 tablet 24 hours after. Now, in terms of cabotegravir, this is important because essentially there were 2 trials that looked at cabotegravir in cisgender women, which was the HBTN-084 trial, and then in MSM and transgender women, which is the HBTN-083 study. And these were placebo-controlled trials. Patients either got TDF-FTC and a shot, or they got, and a dummy shot, or they got cabotegravir and a dummy placebo pill. And essentially, the major results of HBTN-083, which has been published in the Lancet, in the New England Journal, and HBTN-083, which has been published in the Lancet, is that cabotegravir every 8 weeks for prevention was superior to daily oral TDF FTC, 66% superior in MSM with men and 89% superior in cisgender women. So it really is an incredible advance. Every 8 weeks, 6 times a year, an injection, and you're preventing HIV. And the WHO did approve cabotegravir for prevention worldwide, recognizing the cold chain. They again didn't do treatment, but they did put this on their PrEP guidelines, and essentially they are advising this as a comprehensive approach to HIV prevention every 8 weeks. And then I'm going to end with just 2 comments on cure and the vaccines, and then take any comments. There are actually 4 people that have been cured of HIV. I had the privilege of meeting and interviewing one last month, and one has passed away. But essentially, it's very dangerous how they've been cured, right? Because they all had lymphoma or leukemia, and there are certain segments of the population that does not have a CCR5 receptor on their cell surface, and it was thought to be protective against smallpox, and so that's how it evolved. And you cannot get HIV if you don't have a CCR5 on your cell surface, because that helps imbibe it in with the CD4 cell receptor. And so these 4 individuals had lymphoma. They got completely wiped out for the stem cell or bone marrow transplant, and then they got donor cells from someone who did not have matched donor cells from someone who didn't have a CCR5 receptor. And that's how they got cured. So this is not going to be for the average HIV patient, but we're working on other different ways to cure, possibly gene therapy to knock out CCR5, other approaches to look at cure. And then in terms of the vaccine, there have been multiple failures of the HIV vaccine, unfortunately, up till now. However, the COVID vaccine gave people ideas, and the mRNA vaccine technology is so powerful. And in a small primate study, it looked like the mRNA vaccine did protect primates with rectal SHIV exposure from getting HIV. So now there are 3 human trials that are ongoing with an mRNA vaccine for HIV. So let's see how those go. Very excited about those. And I'm going to end here now and take any comments or questions. Thank you so much.
Excellent. Thanks so much, Dr. Gandhi. That was fascinating. A great tour from the history to the future. We'll open the floor for questions. I see Dr. Berger had a question in the chat. Dr. Berger, maybe you want to unmute yourself and let you ask it yourself.
I thought you saw it when you were discussing, I guess perhaps this even gets to some of the shorter but longer acting, or shorter than 6 months, but still longer than a daily pill. With the lenacapavir, obviously people are being reconstituted, going from very high values to very low viral loads in their CD4 counts. But is there, were any of them at sort of AIDS defining complex, or is this drug something, on the hospital side, we could consider somebody who's failed a bunch of treatments or has psychosocial issues, giving to them in the middle of an acute illness? The concerns around iris always there. What do you do if it's not like you can stop the medicine it's in? So complex stuff.
It's actually an incredibly good question, because they certainly didn't do viral loads, say, for example, like every 2 weeks, to see what was happening with lenacapavir. We know that cabotegravir and rilpivirine can drop the viral load to log within just 1 dose. In fact, most of our patients who suppressed achieved virologic suppression within just 1 dose. And so you're right, you can't get it out of your system. And if your viral load's dropping and your CD4 goes up, you are at risk. There is a risk for iris. And we've only seen this studied in a relatively small patient population in the Capella study in the case, but these were patients with MDR HIV, and they were starting with high viral loads, and they were not suppressed. And we didn't see any iris in that case, but it's going to be a risk, and it's going to be a risk we're going to have to manage with steroids if need be, but it's still better than not getting treated at all, right? And so we're going to have to watch that. And then in terms of lenacapavir in the hospital, I'll tell you that we have already gotten from Gilead compassionate use lenacapavir and have used it in our clinic for MDR HIV in the last 2 months. I think it will be used. I think it will be used for both multi-drug resistant HIV. And I think that there will be people, just like we went out on a limb to use long-acting cabotegravir and rilpivirine in a different way. I think there'll be people who use lenacapavir when it's approved, even for patients who don't have MDR HIV. And then they're going to have to put together that data, put together demonstration projects, and hopefully tell us about it, tell us about their experience.
Thank you for that great answer.
Other questions out there? gonna see if anybody's unmuted themselves or.
And it really is just, World AIDS Day. So I'm so happy to be talking to you about it today, just because this week is a very important week.
Yes. All right. Looks like you answered everybody's questions. Thank you so much again for joining us.
Thank you
Really
so much.
appreciate it.
Very nice to be here, and please write me with anything, anytime, anyone.
Will do.
Okay, thank you so
Take
much.
care, everybody.
Okay, bye.